Thank you for the invitation. So we're going to retina and retinal surgery, core retinal surgery in diabetic vitrectomy. And we're just thinking of the tips to identify. So there's 7 small points I'd like to put. One is that you have to know the pathology of the membrane. There is always a second membrane. That's a key point you have to notice. And you always have to look for it. Know when you start peeling a second membrane, you go from far and come towards the pathology. And then you have an option to do delamination or en bloc dissection. Always remember that if you don't remember the second, identify the second membrane, you can get redirected tears, and removing the second membrane allows you to remove the polyp in a virtually bloodless extraction method. So this is the pathology. You have the diabetic membrane on top, but you have a small reflected membrane. That is the vitreous remnants running on the surface of the retina. And that is what is responsible for, one, causing a redirected tear or keeping a blood vessel open after you do it. So this is a few points. Here I'd like to show you this video in which you can see a couple of things happening at this particular point. When it is pulled over here, you can see a distant pull, and this is a PIC fossa, and you can see an elevation of the second membrane going all around the diabetic TRD. And here again you can see the same thing happening. When you pull, you can see tractional effects also. So this is how the second, you see it going all around the diabetic TRD over there. And these are just a few tips. One, look at the vessel. If you see a translucent membrane over the vessel, that's an example of the second membrane. See, you can see when you pull it, you can see a strand going towards the periphery. That's another tip to find it. And you can also see a fold happening. That is a tractional effects when you pull the second membrane off the TRD. This is another video which is going to just show you two different sides of the same polyp. Here you can see a very sharp margin, and the tractional effects are minimal. But when you come to this side, you can see a blunted edge where you don't see the margin very correctly, and you know that at this particular point the second membrane is still there, and that is what the PIC is doing now. It is trying to delineate and separate the membrane from the surface of the polyp. So it's a vitreous sheet starting from the polyp and going on to the retina, keeping it stuck down. So again, this is the main problem. If you don't remove it, you get, when you pull on one side, you get a redirected tear on the opposite side or another side. And this is just to show you that as a horrific thing that I've just done. And you pull it and the tear just enlarges because there is still a membrane on top of the retina, and which is virtually invisible. I'd like to show you what happens when you completely remove the second membrane. You can see in this particular patient, when the membrane is completely dissected off and you pull in the direction of the membrane, once you pull that polyp off, it just comes off easily. That is, if you have addressed the vitreoskytic area properly. And this is another patient in which you can see one whole edge, the second membrane is removed, and even with a micro PIC, a very simple instrument with no suction at all, with a micro PIC, you can just virtually peel off the diabetic TRD without any tractional effects at all. That is the importance of identifying a second membrane. So to summarize, again, I say know the pathology. It's a thin vitreoskytic membrane. There is always a second membrane. It may be extending to a large area, or it may be just at the edge of the polyp. Look for it by clues, sheen over the blood vessels, and attraction while pulling the membrane. Go far to peel it and peel it to the base of the diabetic TRD. Once you do that, you will get a plane to do an en bloc dissection or a delamination. Always think of the redirected tears in a direction opposite to where you're pulling. And when you get the second membrane off properly, you can aim for a bloodless extraction of the fibrovascular polyp. Thank you.
Excellent, Unni. I think you got hold of this is I've been all of us have been facing how to identify the second membrane. So any question? He's beautifully shown the videos how to identify.
Yeah. So so the point is that once you get an edge, that you can create an artificial edge at the membrane, but the point is that when you create an edge at the membrane with your cutter or with insinuation or with indentation, don't imagine that is a point of peeling. From that point, you have to go to the periphery till you see the invisible effects of the membrane. That is the basic concept of the second membrane. That is, you may get a plane close to the visible white TRD, but that's not the plane where you pull. You have to go outside and bring it inside.
That is the reason you don't get so much of plaster that you don't get the edge. That is the main
See, conventional tools we use like forceps are extremely bad. So that's why I have started using the pick where it slices the membrane on one side also when you go. Or nowadays I'm a big fan of just using the suction of the cutter. Yeah, 25 gauge MVR you can use. The pick you can use. There's a new hydro dissection that you can use, the reflux of the cutter. You can just send fluid back underneath the membrane and it just elevates the membrane of using the reflux mode of the cutter.
So Abhinanda, you can use a 26 gauge thoracic needle, which is 32 millimeter. I normally use it, which you can bend very clearly. It goes through a 25 gauge port, and that helps you. I don't need a special. So it bends a lot. It bends a lot. And now I think Sangeet has put up that cutter which is a little bit more stiffer and that can be used. How many times you have to use the bimanual dissection to get the whole membrane off?
I don't do a lot of bimanual. I'm so far so lucky. I've been able to manage with unimanual. I convert very few basically.
And do you ever end up using PFCL a little bit?
I'm very apprehensive of using PFCL whenever the retina is detached. I mean, however much you release the traction, either the fluid underneath the retina is very thick and the PFCL cannot express it, or there is residual traction, and which when you use PFCL, you can get tears along the previous attachment. So I don't use a lot of PFCL in my diabetic TRDs. I would rather let chronic fluid be there, just relieve the traction and let chronic fluid be there, than create a drainage retinotomy over it and try to express it.
Any other comments?
It is done. Visco dissection is something. Yeah, it has been done. Actually, what we have modified that, we've added trypan blue to Visco, color it, and then send it underneath the membranes to get the cleavage plane. It will not tear. It just creates a separation.
No, the
But,
PFCL will not tear. Your tearing will come with the counter traction which you exert. PFCL on its own will not tear. When So typically speaking, historically, Helon was used for the en bloc dissection. It started off with that, and now, of course, people are using.
It's a good point, though. The cataract
Yeah.
surgeon's point is very well taken.
Thanks, Amrish.
yeah, I mean, I'm not saying I don't do bimanual, but I like not to do bimanual. I don't know why.
Then it becomes a relaxing that not me.
Yeah, you have to do. Yeah, I agree with that. You have to do.
Visco
Yeah.
is very useful actually even for macular surgery. When we put the flaps on the macular hole, it holds it even over the disc pit. Otherwise the flaps just keep coming off.
Thanks, Unni.